No, so we have to record the whole thing.
Yes. We can start.
And then
Once it is over, click on
stop.
stop share.
But recording will be.
It will record.
I'll call you. Huh?
Yes.
Now this class is on antidepressants. Now clinical features of depression is sad mood, lethargy, loss of sleep, loss of appetite. Greatest danger is suicidal tendencies. The neuronal changes or changes the brain, deficiency of neurotransmitters at neuronal synapses. Now this diagram shows the neuronal synapses, the junction, and here deficiency of the neurotransmitter at the synapses. And the postsynaptic junction shows increased neuroreceptors. So the antidepressants, what they do is they inhibit the reuptake of neurons or transmitters at the synaptic junctions, or increase the release, or inhibit metabolism, so that neurotransmitters are more available at the synaptic junctions. Drugs which block noradrenaline and 5-HT reuptake inhibitors, tricyclics, imipramine, clomipramine, amitriptyline, doxepin. Drugs which block the noradrenaline reuptake alone, desipramine, nortriptyline, amoxicillin, lofpyramine. These are related to the tricyclics. So this diagram shows reuptake of the transmitters is blocked. So there is more neurotransmitters in the synaptic junction. This is the effect of tricyclic antidepressants. Then there are what those called as selective serotonin reuptake inhibitors, or Ssri. They inhibit the reuptake of only serotonin, fluoxetine, sertraline, citalopram, etc. Atypical antidepressants, they are also related to Ssri, mirtazapine, venlafaxine, trazodone, nefazodone, bupropion. The net result is increasing the availability of amines at the synapses, and the postsynaptic receptors are less active, so increase concentration of the amines at the neuronal synapses. This is tricyclic antidepressants. You can see TCA inhibit reuptake of noradrenaline as well as 5-HT, and they inhibit the reuptake. But they also have other actions. Alpha, muscarinic, and histamine receptors are blocked. So they produce side effects of tricyclic inhibitors. They inhibit the reuptake of norepinephrine and serotonin at the neuronal synapses. So Ne and serotonin. The relative proportion of serotonin activity varies for each drug. Also potent antagonists at various receptors, cholinergic, histaminic, and alpha-adrenergic. These produces side effects of tricyclic antidepressants. So increase the amount of amines at the synapses. Side effects are caused by alpha, histaminic, and muscarinic receptors. Alpha blockade causes hypotension. Antihistamine produces sedative action. Anticholinergic produces muscarinic side effects. So this diagram, this slide shows the effect of this tricyclic antidepressants. Usually response takes about 1 to 3 weeks, and maximal response develops in 1 to 2 months. So the older ones, tricyclics, have marked anticholinergic adverse effects and also risk of cardiotoxicity, hypotension, and tachycardia, etc. Newer ones produce fewer anticholinergic adverse effects. Sedation, dizziness, priapism is a persistent penile erection produced by pain and tenderness. This shows the uses of tricyclic antidepressants. They, in addition to antidepressants, they can be used for headache or migraine, neuropathic pains, and chronic low back pain, fibromyalgia, irritable bowel syndrome, and chronic pelvic pain and insomnia. So these are the other effects in addition to antidepressant action. Neuropathic pain, headache, migraine, myalgia, irritable bowel syndrome, and also as a sedative, insomnia. Side effects include anticholinergic effects, dry mouth, constipation, weight gain, sometimes seizures, and QT interval prolongation. Tricyclics, the side effects are sedation, which is sometimes useful as a sedative for elderly people. Weight gain, increased epilepsy is a problem. Anticholinergic effects, blurred vision, dry mouth, urinary retention, constipation. Aggravation of glaucoma because of anticholinergic effects. Overdose may produce cardiac arrhythmias, excitement, convulsions, coma. Drug interactions with alcohol and antihistamines are common. Ssris, these are the other group of antidepressants. They block the uptake of 5-HT and alone, not noradrenaline, increase the availability of 5-HT at synapses. They downregulate autoreceptors, so they increase release of 5-HT in axon terminals, and postsynaptic receptors increase response, and usually onset of action may be within 2 weeks. This diagram shows the effect of Ssris. Fluoxetine is a classical Ssri, increasing the availability of 5-HT at the synaptic receptors by inhibiting the reuptake. It usually takes 2 weeks to increase the synaptic levels. They are usually located throughout the body and in the GI tract. Advantages of Ssri: no sedation, no anticholinergic effects, less cardiovascular adverse effects. So they are safe, and can be used in antidepressant as well as panic disorder, social phobia, post-traumatic stress syndrome, obsessive compulsive dysfunction, or fluoxamine is used. Fluoxetine has a long half-life of 50 hours. Slow reacting preparation can be given once per week. The Ssris may inhibit the hepatic enzymes. So where there is liver impairment, we have to reduce the dosage and may produce gastrointestinal disturbances, weakness, sleep disturbances, sexual disturbances, etc. are possible. High dose may produce seizures, cause hyperthermia, muscle rigidity, myoclonus, which is termed as serotonin syndrome. Where there is sexual problems, mirtazapine or bupropion can be used instead of the fluoxetine or fluoxamine. So they inhibit the hepatic enzymes. So there may be interactions with drugs which are metabolized in the liver, antipsychotics, benzodiazepines, and carbamazepine, because they produce potential inhibition of hepatic metabolism. Commonly used are fluoxetine. Paroxetine is sedative. These two inhibit hepatic enzymes. Fluoxetine is the longest acting, can interact with tricyclics and neuroleptics, beta blockers. So if you are changing from one group, you have to give a washout period of 2 to 4 weeks. Selective serotonin reuptake, that is SNRI, serotonin norepinephrine. These are slightly different from SSRIs. They also serotonin and noradrenaline reuptake, duloxetine, venlafaxine, desvenlafaxine. They have also no antihistaminic or anticholinergic side effects like tricyclics. SNRIs, venlafaxine, duloxetine, and they are useful for antidepressants, neuropathic pain. They produce less inhibition of hepatic enzymes, may produce, should be careful about nausea, dizziness, constipation, and impotence. Duloxetine should be avoided in patients with renal or hepatic disorders. Atypical antidepressants, these are slightly different from SNRIs and SSRIs, trazodone, methadone, etc. They have a different type of mirtazapine. They have slightly different effect on the neurotransmitters. They inhibit dopamine and noradrenaline reuptake. Therefore, this can be used to decrease the craving for nicotine and bupropion. So tobacco abuse, it can be used. Mirtazapine blocks 5-HT2 and alpha-2 receptors. There is increased release of 5-HT and noradrenaline. So they have antidepressant as well as sedative action, increases weight and appetites. No interference with sexual dysfunction as like SNRIs or SSRIs. So mirtazapine is specifically useful when there is sexual problems. It has got high affinity for 5-HT1 receptors. Trazodone blocks mainly 5-HT2 receptors and alpha receptors. They block the presynaptic receptors, which means they increase the release. They also produce some H1 blockade, may produce sedation. Meancerin as alpha-2 blocker. There is increased release of noradrenaline. It can be used in anxiety and panic attacks. Mao inhibitors is another group. They inhibit actually the metabolism of amines, moclobemide, MAO A and B inhibitors, tranate substitutes. These are blocking the metabolism of amines, but they are of limited use because of adverse effects. Phenylephrine, tranylsubclamine, irreversible inhibition of monoamine oxidase. They are limited use patients who are unresponsive to other atypical or tricyclics. There are problems in BP, food and drug interactions because of increased liberation of amines, increased heart rate, arrhythmias, stroke, etc. They should not be given with Ssri. There is increased risk of serotonin syndrome. So if we change at least 6 weeks after Ssris only, we can use these drugs. They are not commonly used nowadays. As you can see, their action is mainly inhibiting the metabolism of amines. Normally the MAO makes it amines inactive, but MAO inhibitors really decrease the metabolism of amines, but one particular reaction is common with this group of drugs. Tyramine, which is present in cheese, increase the release of noradrenaline, and that is not broken down by MAO. So there is increased noradrenaline at the synapses, which causes adverse effects. Now, the third group of drugs used as psychopharmacological agents is anti-manic drugs. Lithium carbonate, which is a mood stabilizer used in what is called as acute mania and also for prophylaxis. For lithium, instead of lithium, we can use carbamazepine, sodium valproate, lamotrigine, etc., which are anticonvulsants and also olanzapine. Lithium actually acts on overactive neurons. Now, mania is a condition where there is excitement, overactivity of the neurons, as well as depression. So, lithium inhibits the renal signal transduction in the overactive neurons, blocks the conversion of IP2 to IP1. So, supply of inositol is decreased. There is decreased release of IP3 and diacetylglycerin. This will reduce the activity of this diagram shows IP2, IP1, IP2. Now, lithium acts at the terminal stages, IP2 to IP1 and inositol. So, it blocks the conversion of IP2 to IP1 and inositol. So, this will reduce the availability of inosine phosphate at the membrane. So membrane becomes less active. Lithium used in MDP, which has got a narrow therapeutic index. Safe blood level is 0.5 to 0.8 milliequivalents per liter. Toxic effects 1.5 milliequivalents. So blood level should be checked frequently. It can produce interactions with sodium, diuretics, increase sodium accretion, may cause sodium retention, depletion, and retention of lithium can cause toxicity. Dose is usually 300 to 600 milligram. Effect is seen after 10 to 15 days, but it can produce side effects like tremors, mental confusion, diarrhea, hypothyroidism, and teratogenicity, which is an unpleasant effect of lithium. So in a patient who cannot tolerate lithium, valproate can be given, sodium valproate can be given, or it can be combined with lithium, which will produce side effects less. Ravi? I finished that. What shall I do? Stop share?
Yes.
But whether it is converted?